Um, all right, sorry I'm not there, folks. I'm at the American Society for Neuro Rehab meeting in Charleston, and it's just the timing of my lectures. So I hope the internet works fine. All right, so today I'll go through the, just introducing myself. If there's any, I know some people from Jefferson were invited, so welcome, and externally. My name is Dylan Edwards. I'm the director of the Mass Rehabilitation Research Institute, and it's a pleasure to be able to speak with you today. The topic is challenges for translation of neuromodulation in rehabilitation. And grateful as always for the support from the Shrier family for this lecture series. We're indebted to them to be able to continue this. Marc and Nancy Shrier. There's no financial relationships to disclose for this meeting. And the objectives, I believe, were previously circulated. So, and you can hear me okay, right, if I launch into this?
Yep. Yeah.
Okay. I may not be able to see if you put up your hand or something, so possibly you could just try and yell out if you want me to clarify something. And there should be time at the end for questions as well. So this is about translating neuromodulation, and I'll give a definition of that. And I guess the upbeat perspective is that electromagnetic, non-invasive neuromodulation, or stimulation at least, can categorically generate electric fields in the brain that can meaningfully impact that brain's activity. And there's concrete evidence of that. So that's categorical. And that's been leveraged in the field of psychiatry for application for neuromodulation and treatment. But the field of neurorehabilitation has not yet got sufficient evidence for this method to be used clinically in a clinically meaningful way. So it's upbeat in that other fields of medicine seem to have made some advances. It's what I'll present some of my progress and challenges over the years that I've tried to approach it, and some contemporary things that we're looking at the moment. But again, I think there's hope, there's merit, but we're not there yet in rehabilitation medicine. So what do we need to do? So the overview of what I'll talk about here is the need for more effective treatments. I'll define neuromodulation in context for those who are not familiar with this field. A perspective on translation for the way I think about it, and also the way that others think about this word translation. Some examples of studies that I've actually done in the different ways translation can be applied in research. And then finally, some suggestions and open problems for the field. Okay, so we need to ameliorate disability from neurological conditions. I think we're all well aware of that. And just some data from World Health Organization. The examples I've drawn today are from stroke and spinal cord injury. Stroke has a really high prevalence, and the aging population and the advent of and the advances of acute care medicine that have led to a lot more stroke sufferers actually surviving the stroke, and that's led to more disability, that we have to deal with because people have this residual impairment. So it's a continuing and growing problem for which we don't have strong treatments other than behavioral therapies, which have some benefit, but clearly they don't ameliorate the symptoms completely. In spinal cord injury, this is also prevalent, not as prevalent as stroke, but is really quite devastating and traumatic, and often happens in a younger age demographic. So people need to live with this condition. The patient themselves and their family and society at large has to care for these patients for a much longer period of time. So socioeconomically, it's a large burden as well. So I'll be talking about adult stroke and adult spinal cord injury in this presentation. And I'll start by showing this figure that you can find many of these types of figures on the internet, but they indicate the kind of pathway and the obstruction, moving something from a basic science to applied clinically and making a meaningful difference in the community. And they describe this valley of death. So it's a nice little illustration of a challenge moving something from academia through to clinical application. And on the right, you have a large list of the challenges that we come across that I'll touch on later as well. So in this talk, I'm going to be talking about non-invasive electromagnetic stimulation. And there's two main flavors, the transcranial magnetic stimulation and transcranial electrical stimulation. And this is a busy slide that I might have shown in the past in presentations. It's from a book chapter that I co-wrote a couple of years back. And it illustrates in many different ways that these methods are used experimentally. And so on the left here, you have sort of biomarkers and to understand mechanism, pathophysiology. And then you also have the various treatment approaches that can ultimately be delivered as a monotherapy, which I always found surprising. So that means just delivered without considering the brain state at the time of delivery, or as a combined combinatorial type therapy where you're applying it in combination, some temporal proximity to another therapy, whether in particular I'm interested in behavioral therapies, but plausibly it could be other types of therapies. So today I'll be talking about this, the treatment end here and the challenges associated with the application of these two methods in neurorehabilitation. So what is translation? And this is how my brain thinks about it. So we have, I guess, 15 or so years ago, when I started working in neurorehabilitation in the US, a lot of my colleagues were working at this end here with preclinical models of neurological injury and recovery. Even to this day, I have a lot of colleagues that are working at this end. And their idea of translation is moving it from the bench and from preclinical models right through to patients. But of course, we know that you can move ideas, theoretical ideas, grounded in the knowledge of brain structure and function and of the pathology into plausible hypotheses that you can test experimentally, and also back in the other direction as well. So translation means different things to different people depending on where they are in that spectrum of studying disease or treatment or neurological function, and ultimately with the goal of helping patients. If you look at a more formal definition, this is from the National Center for Advancing Translational Sciences. We read here on the right, the translational science spectrum represents each stage of research along the path from the biological basis of health and disease to interventions that improve the health of individuals and the public. And they go on further to say that the spectrum is not linear or unidirectional. And you can see the various components in here, which is interesting to stare at for a little while. There was historically a two-phase description of translational research that in about 2014, I believe, the then Institute of Medicine requested that the Centers for Translational Science, the CTSCs, that were funded nationally review these phases, and they came up with this 5-phase structure. And essentially, it's still moving from between academia through to communities. But if you just have a look at this bottom gray row here, it's a little bit more granular. So the T0 is basic research, T1 is translation to humans, T2 is translation to patients, T3 is translation to practice, T4 is translation to communities. And I think these illustrations are worth looking at. There's another one that I pulled down from the internet, I think from Vanderbilt. This is the same concept, but it has additional information that I think is interesting. It has the phases of clinical trials listed and how they relate to these translational phases. So in T1 is phase 1 clinical trials, T2 is phase 2 and 3 clinical trials, T3 is phase 4 clinical trials. And the other thing is, what's useful with this figure is that you can see the arrows go in both directions. So this is a bidirectional pathways. And ultimately, of course, we're trying to get true benefit to society over on the right. So with all of that in mind, thinking through some of the things that I've done, I'm going to give 2 examples of non-invasive stimulation. And there have been others that I've done, but I thought with the best use of time, I'll dig into a couple of examples. And so one is transcranial direct current stimulation that I haven't given up on, but I've had various successes over the years. So let's talk about the early stage studies. So between 2000 and 2009, and this is for stroke motor recovery, by the way, there was this model that was proposed around 2006. And you can see this in many different papers, this concept. And in fact, the prevailing thought, interestingly, about this interhemispheric imbalance when you have a unilateral lesion of excitability, I think still exists. And it's not that it's illogical, but it's probably not the way, now as we know, it's a broader network. And it's more complicated than a simple model like this. I think people knew it was a simple concept and a little bit simplistic back then, but there were quite a few studies that embarked on this. You have a unilateral lesion. The idea is that the outflow to the contralateral limb is reduced. The transcallosal inhibition to the contralesional hemisphere was lost, and so you had an increased excitability of the contralesional hemisphere. I think you can see my mouse there. And so there was a bunch of studies that thought, with that logic, we'll try and upregulate perilesional cortex on the affected side or downregulate excitability on the unaffected side, or both. And so around that time, I think 2007, 2008, I thought about trying this transcranial direct current stimulation. You can see the pads here. This figure shows a anode electrode and also a coil here. These are different experiments. It's just illustrative here. You can do high frequency stimulation with a TMS coil or anodal stimulation to get the same effect putatively. And in 2009, we published that indeed to the hemiparetic forearm of chronic stroke participants, we could take a motor evoked potential that had waveforms like this. These are sample representative waveforms of the group. And after 20 minutes of 2 milliamp stimulation, the waveforms grew in amplitude across the group. Again, these are just sample representative waveforms. And what I was interested in actually is first of all, if that could happen, and we showed that it did, but then also if that could be sustained during a subsequent behavioral training for about 45 minutes, and it was. And then, so that was the first evidence for me that, okay, this could be worth pursuing. We subsequently looked at the timing of stimulation for a very specified movement. The protocol, I believe, was just wrist extension in patients who had wrist extension difficulty. it may have even been the robot that brought them back passively, and they just practiced the extension phase of the movement in combination with transcranial direct stimulation. And they had several parameters of the movement that could be improved with a single exposure to this transcranial direct current stimulation. We subsequently thought about, well, the timing might matter. So we wrote a framework about how you might apply in this framework paper. It was RTMS as the example, because I thought this might be useful to the psychiatrists who are also doing neuromodulation, but the concept is the same: when to apply stimulation in relation to the practice. And I'm still very intrigued by that. Interleaving it, priming with a full neuromodulation session prior to the practice session, after the session. It's an open question, but in the study for this particular application, we showed that priming prior to the practice was the best approach. So this is, I guess, why I'm showing you this is it's just some select publications that are talking through the sequence of my thinking, trying to advance this to something that's not a single exposure with a fine measure of motor control. It's moving towards multiple sessions with a gross measure of function ultimately that might have some meaningful and lasting impact. Because all of these studies that were over on the left side here were all modest effects and short-term effects, so hardly clinically tractable. But that got us excited enough to run a clinical trial. The results are here, published in 2019, and I was the PI. It was a dual site trial. And you can see the basic setup here. We had anodal stimulation and a robotic training paradigm. The same as I was saying before, they would do brain stimulation, anodal stimulation with the anode over the affected hemisphere, and 20 minutes, 2 milliamps prior to a session of robotic training, and that was repeated for 36 sessions. So that's a lot of, that's in the order of 1,000 repetitions per session, so 30,000 movements. So it's a hefty training paradigm, a lot of effort for everybody involved, with the patients who have to drive in and get this treatment every time. But at least it's in the order of what the animal literature recommends for behavioral training, where you need many, many repetitions, far more than what's done clinically. What did we find? We found that in both the real stimulation group and the sham stimulation group, patients clinically improved. And you can see that, you know, they were stable at baseline, but then they improved by, I think it was about 6 points on the Fugl-Meyer score, but it was clinically meaningful, above the clinically meaningful difference of 5.5, and in both groups. They also improved clinically on a motor function test, the Wolf motor function test. And that was sustained at 6 months. So the patients were happy because they improved and they had a sustained benefit. The scientific question was, is the supplementary TDCS effective? And it's not, it seems, or the sham is doing something. So it was great for feeling good about helping patients, great to provide evidence in support of behavioral training, having a clinically meaningful and lasting benefit, but not useful for telling, you know, for getting a stronger benefit from the DC stimulation. Okay. So was it worth running this $5 million R01 trial that, you know, patients did 36,000 movements? Yes, I said, I think it was. Why was it worth it? We showed that behavioral training was effective, and we also showed that the MEP, the motor evoked potential, could predict response to this behavioral training, not the TDCS component. There's no evidence to me that it would provide a superior effect, even when we looked at cortical versus subcortical and other characteristics that might be predictive. We'll come back to that because I think we've made some advancement on that in recent years. We showed that it was tolerated. Plausibly, people may have recovered faster with the DC stimulation. That's an open question. The trial wasn't set up to look at sensitive measures of change over time. We just had to, you're limited with how many time points you can have and how many outcome measures you can have in these types of trials. So that is an open question that would be useful. If you can get a clinically meaningful benefit in a shorter amount of training sessions, that would be useful to know, and it's not possible to know that at this time. Was the outcome measure selection correct? I think so. The primary outcome measure was Fugl-Meyer, but we also measured the Wolf motor function as well, and it saw the same thing. The timing of the TDCS, contemporary studies are combining the DC stimulation during training. Could it have been better during training? Maybe. We did consider responders and non-responders, and we don't have any insight as to whether it was helpful for a particular subpopulation. Unfortunately, this didn't have sophisticated neuroimaging. It wasn't within the budget of this study. And that would have been incredibly useful in hindsight to know with the lesion load and lesion network disruption to see if there were some responders to that. So what's next? There are many different things that could be explored: adjusting the trial conditions, conducting earlier phase studies for further exploration. I think that unless we can find something in the responder analyses from these patients, like a particular subpopulation that did respond, that's where I would put my money, is going back and doing greater exploration for some of these early studies that then lead to the clinical trial, that inform the larger clinical trial to get a more robust effect, or in a specific population where it's rationally applied. Now, there's an ongoing StrokeNet trial that we're part of. The PIs are here. I believe they're going out for lunch right now as I'm giving this talk to talk about the trial. And this is a bilateral stimulation, transcranial direct current stimulation. As I did here, you can see that the gentleman in the top right corner with permission, but they're stimulating bilaterally and concurrently with training, and at a much higher, double the dose that we are applying, 4 milliamps. And they believe 4 milliamps is important. We're also testing 2 milliamps in this trial. And so it will be interesting to see the results of this study. All right. Another second example, this is using repetitive transcranial magnetic stimulation for recovery. And this is in spinal cord injury this time. And this is a different kind of translation where I'm going from the previous one was going from a theoretical model of brain network imbalance and excitability problems to this is going from an animal model through to the human. Okay, and repetitive transcranial magnetic stimulation is where you have multiple pulses of this magnetic stimulation with the coil that you'll see in a little bit. Now, between 2002 and 2015, there was the development of this idea. So during the developmental period of the CNS and the peripheral nervous system, long-distance axon growth is in part mediated by a biochemical pathway intrinsic to the neuron, so inside the neuron itself, called the RAF-MAP kinase signaling cascade. So what that means is this particular pathway is known to be important for growth of axons, in part. Okay. So, but that's in development, and then that of course shuts off, and it importantly shuts off so that after this initial a growth period for stabilization purposes and for a functional nervous system. So the idea is, can you reactivate it? Can you reactivate this pathway? So in 2020, well, actually this started a long time before 2022. Yeah, these experiments take some time, so I can't be sure exactly what year this started, but they showed that genetic activation in corticospinal neurons resulted in corticospinal axon sprouting and regeneration in 2 experimental models of spinal cord injury. They improved motor functional recovery after injury through new synapse generation of these sprouting corticospinal collaterals. And then as part of these series of experiments that I was involved in advising on, there was the idea of applying high frequency repetitive transcranial magnetic stimulation because in other parts of the brain, not corticospinal neurons, it had been demonstrated that electromagnetic fields could actually have a similar effect to this genetic activation. And so a colleague of mine said, well, you generate electromagnetic fields in the brain with your TMS, could we try that? So we took a TMS coil to the animal lab and we started stimulating. So it's kind of like a bedside to bench direction of translation. We didn't know if that would lead to anything, but we showed that high frequency rTMS could activate the signaling that also led to CST sprouting, regeneration, and functional recovery in rodent models of SCI. And actually, this was just published in January this year. And this was a mountain of work, as I said, that had multiple experiments, and I think lasted around about a decade, maybe just under a decade. But you can see here, this is the model they used for the experimental paradigm that they used. But essentially, they showed that with high frequency rTMS, high frequency is 15 hertz, I believe we used, around threshold or just above threshold. We could see collateral sprout, cross sprouting in the corticospinal system. That was in the knockout mice where they didn't have this particular pathway, even when you use the high frequency stimulation, and wasn't in a sham stimulation group. So it was absolutely attributable to the brain stimulation. Another experiment showed growth actually through the lesion site itself, which is atypical. It's not very far if you look at the distance from the lesion in micrometers. Oops. Sorry, my computer's verifying something. But nevertheless, they had growth that was not present in the sham stimulation and not present when they had genetically modified these mice to not have this pathway. So it was attributable to this signaling pathway, and it was caused by the high frequency stimulation. So these mice had functional regeneration, synaptogenesis, an improvement in, they had a hind limb experiment and a forelimb experiment, and the behavioral correlates of that with stepping, etc. And other control experiments where they went and knocked out these pathways that had recently formed and they lost the function. So it was a very, very well-controlled study, but this is in the mouse. And so really exciting work and very nicely controlled. We can't do this level of imaging in the humans yet, but we're making progress actually with colleagues, starting to talk with colleagues at Jefferson who do imaging of the spinal cord. But what to now? So we started as part of this project to work with colleagues at the Martino Center in Boston, where they modeled the electromagnetic fields, and they had a mouse model of that that they developed for this paper actually. And the idea of that was to prove that we were not stimulating the spinal cord directly, we were actually stimulating the brain of the mouse. You can see with the electromagnetic fields here on the right, that was my pointer. It's a large, it's not really possible to be focal. We're not really even that focal in the humans with these coils, but in the mouse, it's harder to be focal. So we are absolutely stimulating a large swath of cortex, but we are not stimulating the spinal cord. That's what these models proved. So it was a cortical effect that we're having with the electromagnetic fields. All right, so what's the purpose of showing you all of that? I'm super excited about this, by the way. And in fact, we're inches away from a PA state grant, investigator-initiated grant. That's like an R21. to actually implement this in humans. And I just received a notification today, actually. So what to do? How would we translate this to a human? What do we need to think about for translating this to a human? Is it safe? How do we take it from a mouse model to the human model? It seems like a bit of a jump. So here is the mouse model. You can see the rodent coil, the mouse, and now we want to translate that to a human. So what do we do? Well, we've got a circular coil for the mouse, which we know that it stimulates motor cortex because we can see their little arms twitching and little forepaws twitching. But it's a circular coil. Well, we have circular coils in humans. We could put a circular coil over the top of the head, but we're probably going to be stimulating a lot of cortex that we can't rationally think that that's doing something meaningful for the corticospinal effect. So we're thinking that we'll limit that to corticospinal stimulation, which is why on the right here, we're modeling 2 figure-of-8 coils simultaneously. It's spinal cord injury, so they're going to have both arms affected. So it makes sense to stimulate, whereas stroke, we usually target one or the other hemisphere. So we've made progress now with our modeling partners. Luckily, they have a P41 grant. They're also leveraging that. They're spending a lot of time developing these models, and they're getting very precise. So in a separate side study, we're validating their models with, we will send them an MRI scan of a patient, and they will send us, with knowing the type of coil we use for stimulation, they will send us exactly what settings we need to use in the coil to get this part of the cortex with the electric field density that we need. And we are going to do a validation experiment where we'll confirm that. We know that we need around 80, 90 volts per meter to elicit a motor evoked potential. And we'll see whether their models stand up to this prediction by testing it experimentally. If so, we'll use this, we'll MRI scan the spinal cord injury patients, and we'll let our modeling colleagues tell us what stimulation intensity to use to have the desired, because it's hard to elicit a motor evoked potential in a spinal cord injury patient because the pathway is cut. So we're making quite strong progress, by the way, in electric field mapping of the brain from TMS that we think is going to have applications well beyond this project, including in psychiatric application, where it's still quite crude as to how they define treatment dose. Okay, so that's where we're moving with that. We have this consideration of safety. You can see this is published data showing on the bottom is the pulse frequency. So the faster you stimulate with TMS, the higher the risk of a seizure, and there's safety limits that you need to stick by. And so you have this thing called a train duration. The train is the length of the number of pulses, and so as the frequency increases, you need to decrease the length of the train, and so that's what this blue line represents. And the red dot is right where we're right on the edge of the safety limit for this. So we're going to have to. We are within the safety bounds, so we have data to support that, but we need to be careful with this study. All right, so, well, in all of these cases, actually, the first thing is about team science. I'm not a solo lab doing this. I just, let's work backwards what I just showed you. This modeling work from MGH and Martino's Center is critical to the advancement of what we're doing. Perhaps we could get away with not having them involved, but it's much tighter experimentally with that insight. So the team science really works, and it's you learn a lot from people. These people are engineers, and they come from a different sort of background, but it's helpful, and they don't have as much clinical involvement. What other lessons? Oh, and so what else? Well, the other example I gave with TDCS, I started with a colleague in Boston, Felipe Fregni, who's well known in the TDCS field. collaborated with MIT for the robotics, a clinician, Bruce Volpe from Long Island, who was, and Cornell prior to that, who had done a lot of work in stroke robotics. So it was really, and Alvaro Pasqualeone, a brain stimulation expert as well, was on that grant. A nice team to work with actually for developing this idea and cross-checking ideas. Okay, what's the next steps for this for the spinal cord injury? Is this human feasibility trial that we're about to start, and we're writing a proposal now for early stroke application as well. Still thinking about safety in the stroke population, but certainly in spinal cord injury, where they don't have, this is in the absence of a concurrent TBI, so they haven't had the patients we'll select don't have brain injury as well. We're more concerned with safety for the stroke population. But feasibility, well, it's a short treatment. It's only a 10-minute treatment. So to do 10 sessions as an inpatient, we think is a pretty light lift. It'll just be at the start of their therapy day. TMS machine will come in, they'll get a 10-minute treatment. Hardly the same as these chronic trials where a spinal cord injury or a stroke patient comes in for 36 visits from their home and does 1,000 repetitions. So we think more of a captive audience at an important time in recovery. So we're optimistic about this feasibility. Planning for an efficacy trial if it is successful, and going back to the animal studies with new questions. So we've talking about other ideas that this opens up, and we can go back and test in the animals. So I've presented 2 examples, but there's others that I've worked on. 1242. So I guess in the last few minutes, just let me talk about a couple of other examples. The top 2 are RTMS. The top left one is a low frequency repetitive stimulation protocol in the chronic hemiplegic stroke patient 3 to 12 months after their stroke. This was called the NICHE trial. It was published in Stroke a few years back, and it showed, similar to that TDCS trial, that we couldn't see an effect above the training. So it was coupled with repetitive behavioral training that Richard Harvey, the PI of the overall trial, had developed up in Chicago. And the training was robust, it seems. The same thing, the sham group and the real group improved clinically, had a sustained improvement clinically. So this is great for behavioral training, quite different training than the robotic training. So it seems like lots of repetitive practice with progressive overload and some of these rules that we know are important for improving. It seems to be a common theme across these behavioral, meaningful gain and improvement if you do enough repetitions. But the RTMS was not superior. There's another publication, there's another trial called the EFIT trial. I'm the lead author on that, and we submitted last week to Stroke, and it's under review. And this did a follow-up trial to this NICHE trial using a different sham coil because both groups improved. We thought maybe the sham was doing something. The same end result. We're going to show a significant improvement in both groups. Now, a colleague in Boston at Brigham and Women's has reviewed these data and looking at lesion load and network disconnectivity, and has a different take on these data. So I won't say any more about that, but when you have a clinical trial, you need to have a predefined analysis, hypothesis, analysis, and you must stick to that and report it. And so that's what's going to be reported, that low frequency stimulation, when you take stroke as all comers, cortical, subcortical, left or right hemisphere affected, you won't see an effect when you target the contralesional hemisphere for the brain stimulation. It's plausible if you analyze for, and reasonable actually, if you analyze for where the lesion was, how the network was disrupted, and whether it was rational to actually target that contralesional hemisphere with an inhibitory protocol, there might be a different story. So that's enough on that. The top right trial was from McGill, Alex Thiel, who I wouldn't mind if he can give a lecture at some point at Moss. He's interested in aphasia recovery, and I participated in a trial that he was leading, 3 sites. It was my lab in New York, McGill, no, I think it was more than 3 sites, but it was Canada, US, and Germany, which is interesting because it's multilingual as well. But in this trial, they did see an effect of 10 days of inpatient application of low-frequency stimulation targeting pars triangularis in the contralesional hemisphere, so the Broca's area homologue in the contralesional hemisphere. So that's worth thinking about, actually. And it's not my expertise in speech and language recovery, but this, I think there could be something here in that there was an effect if you treated patients early. And we report a similar thing, but it wasn't significant in the niche trial I was just talking about. There looked like there may have been a benefit, but it washed out in the multi-comparison statistics of treating people early with low frequency stimulation. But that's worth having a look at that paper if you're interested. And then a couple of other things I've been working on at different stages. So the one on the bottom left is spinal associative stimulation. It's a method of improving, a method that I developed actually after I was a consultant for a while in Barcelona, and I got to work with a very talented neurophysiologist, Josep Valsolet at the Clinic Hospital in Barcelona, and he was an expert in clinical neurophysiology and could stimulate the brain and the spinal cord via the peripheral nerve and cause a collision in the spinal cord. And it's a powerful collision, and this is in the healthy brain. And I thought, well, we might be able to capitalize on that for neuromodulation. So I showed that we could repeatedly give that timing and modulate the spinal excitability. So this means that as you have a descending command coming down from the brain, the spinal cord is more responsive. And so there was an editorial written about this paper, and that's reasonably well cited, actually. And we have some unpublished data in spinal cord injury. So all of that was healthy subjects. So we're moving that from theoretical idea, healthy subjects testing, and now we have some data in spinal cord injury. And there's another one, the bottom right as well, with DC stimulation, which is also interesting, targeting the brain in spinal cord injury. And so most people are targeting, with reasonable effect actually, targeting the spinal circuits. There was a nice paper in Nature Medicine about 2 weeks ago from colleagues at University of Pittsburgh and other collaborators with this epidural stimulation. But the bottom right one is non-invasive stimulation targeting the brain. And I think with that, so you have a more responsive spinal cord and more stronger descending command in a weak corticospinal system after a spinal cord injury. I think it has merit. All right, so those are just some other examples that I glossed over relative to the other 2 that I went into with more depth. So in conclusion, what do I recommend for successful translation of neuromodulation? Well, we need solid theory, rationale, and a working hypothesis for any treatment. And I guess that's what I'm trying to do with neuromodulation. So if neuromodulation affects excitability, is the excitability of that part of the brain or a network that part of the brain interacts with, is it pathologically disrupted as a result of the your disease of choice pathology? So that's my first question. So in depression, they target the dorsolateral prefrontal cortex. And so my thinking, not being a psychiatrist, but thinking of, because in psychiatry, they've made quite some strides in treatment. What was the rationale for targeting that part of the brain? Was it, how do you even assess excitability as we do in the motor system? So to me, it's much, I'm a motor systems physiologist, so it's more, it's easier for me to see, it's more concrete. Excitability is reduced, You enhance excitability with these methods, and it has both an excitability change and the corresponding motor performance change. That's logical to me to then make a step towards applying that repetitively for treatment. It's less clear to me where you don't have that overt excitability change or you can't measure it. So have a solid theory or rationale. That would be my logic. Understand. Oh yeah, and it's a long and winding road to developing a new treatment. Conception, evidence, regulatory, adoption, with experience with this actually, and would probably echo this. So it takes a long time and requires resources and persistence. And if we think about that, this translational study in the mouse that I'm involved in, we've already spent 8 years just to get that Science Translational Medicine paper out, this 40-page manuscript with 15 different experiments or something. To get that to adoption, it's a long time, requires persistence. So don't give up. Yes, that's a good message. Understand the literature and interpret the literature with care. And one of the things that strikes me about clinical trials is, so you have a hypothesis, you set the statistical analyses to support or refute that hypothesis. And it might fail, like the 2 neuromodulation trials where the hypothesis was that you will have a greater improvement in the treatment group than the sham group. But both were kind of getting treatment because they were getting this intense behavioral therapy as well. So when a trial like that fails, does it really fail? I mean, we learned a lot from that. And we learned that behavioral treatment is highly effective. And I don't know enough to talk about this trial, but if we think about the recent trial in depression and stroke and serotonin reuptake inhibitors that failed, there were 3 trials, I believe. It's scary to say that they failed when it really might help people. And, if you have an outcome measure that's crude, like the modified Rankin scale or something, and you take all comers, we need to think, I think we can learn a lot from trials, even when they say that it didn't work. It didn't work the way they applied it, using that outcome measure. So just keep that in mind as you're digesting the literature. Pay equivalence to whether a trial was actually set up for, pay attention to whether it was set up for equivalence or superiority. So the tele-rehab trial I published with Steve Kramer was the PI on that in JAMA Neurology some years back, was a non-inferiority trial. So that was setting out to prove that at home could be comparable to in clinic. So just pay attention to those things. It was never intended for one to be superior to the other. It just might make practical sense to do one over the other. And be scientifically critical with your interpretation. Reproducibility, this is tough because we should be reproducing other people's results and reproducing our own results. Or asking a collaborator to try and reproduce our results. But, how do you get funded to do that or inspired to do that if you ran a good study? But it is important, especially in neuromodulation. We need more studies that reproduce results that people think are robust. One of the ways of making things reproducible is standardizing the way we talk about the treatments. And so I was involved in this paper with a colleague, Maron Bigson at City College in New York. And we've tried to define how to talk about. So when people are writing in their manuscripts and they're trying to define dose and the parameters that they've used, we're all talking in the same space and it's not so esoteric. Know and grow your own expertise. So where do you fit on this spectrum? And what's your purpose? What's we've talked about this, and you and the group at MRRI really, I think, have a solid grasp on this. So I'm kind of talking to experts and preaching to the converted, but it may be possible to move something from this mouse model all the way through to the community implementation, or maybe it's not. One thing that I have learned is if you have the really tight skills as an animal experimentalist, you may not be the person who understands the phase 4 clinical trial or knows what to do, or vice versa. It's atypical. Maybe you can learn those skills along the way. So know your skills and where your work fits, and it's okay to work with others to build that. So this speaks to that, you may have limitations with your own. I guess I fell into clinical trials when I was starting this just over, let's say, 12 years or so ago, and the clinical trials definitions and clinical trial registry was just starting to build up and get really strong, and reporting and everything. I was kind of learning as I went. I don't have a master's in clinical trials, and yet now I've done a few clinical trials, and including this one that we have under review at StrokeNet, which is a 25-site trial, a phase 3 pivotal trial that I'm a PI on. And so, wow, it's impressive to work with other people who know all of the bits and pieces to go together in a big clinical trial. And I've come from a neurophysiology experimental background. So I would say that either you need to learn that as you're going, which you should have a good understanding of that, or partner with others that do. But know your place and the thing that you bring to the table in this translational pathway. And team science is really important for that, and we've had great lectures as part of our T32 series on that. And if you have a look, this is striking to me. Have a look at all of the stakeholders that have got to work together for successful translation, and have a look at the list on the left. So the researcher and the clinician, so that's us, I guess, the researchers and the clinicians are only a small part of this huge long list of people that need to be involved to make it successful. So baby steps, we do our small part, move it forward. And I think that is important. Incremental science done really well is key. Then trying to go straight for the top by not having a well thought out, a non-rational trial. Acknowledging all of the people that I've worked with who have helped with the data that I've presented. That's quite a bit of work actually that I just presented today. And I guess I'm just going to stop there and open up for any questions in the last couple of minutes.
I have a question.
Yeah.
Can you hear? Yeah. So I'm trying to wrap my head around the theory behind the TDCS and your RTMS trial. And I think a lot of it is just, it's a little bit out of my area of expertise, obviously, but so you showed that TDCS can increase MEP amplitude over lesioned cortex, and that increase in MEP amplitude is sustained after an intensive bout of robotic training.
Right.
So is that increase greater? So is the increase with TDCS, is that greater than the increase? Like does an intense bout of behavioral training, how does that change excitability in lesioned cortex?
That's an important question too. And we didn't get into the training itself. That experiment wasn't done. The question was, at the time, my colleagues were applying TDCS with no training at all. So the treatment of the day then was that this was a new treatment. You don't need to do behavioral training. You just do multiple sessions of TDCS. And I thought that I don't buy it. I think it's going to be a short-lived, modest improvement. We probably need to couple it with training. And so the question, I know that this kind of behavioral training leads to a sustained improvement because the colleagues had published in the New England Journal of Medicine. It still was, and it was a standardized protocol. So my question was, I think it might augment a training effect rather than just be a treatment by itself, a monotherapy. And so the question I presented to you was, they may not be complementary. They may not be complementary. The training itself might abolish this effect. And so I wanted to understand if
That's why I wonder if training alone, like what are the changes? Because I wonder if, you know, could the reason why you're not seeing any difference is because you're getting some kind of occlusion effect in cortical excitability. And so it's just, you kind of either the TDCS or the training, either one kind of, you hit your limit and you can't bounce it any further.
Yeah, that's possible. That's a good question. That's a nice question, actually. And I would like to do that experiment. We decided to, rather than go down that path any further, that reviewers would probably like a next iteration of some kind of assess of a clinical measure. But I really like that idea, whether you've hit an upper boundary from the training itself. And so, yeah, the answer is that that's never been done with that robotic paradigm as to what effect that has by itself, which is natural. I like that thinking. Good suggestion. All right. Wow, that seemed to go fast. I think we're probably out of time. If anyone have a last question, or we can probably just wrap up.
I had one quick question, Dylan.
Okay, if you need to drop off, go for it. Otherwise, yeah, please shoot.
So when doing the spinal stimulation and the brain stimulation at the same time, how would that been described to feel like? Because I can't wrap my head what that would actually, yeah, what the sensation would be to have a signal going from the spine and the brain at the same time and colliding.
Yeah, so you feel nothing in the spinal cord. Where you actually feel it is at the site of stimulation. So the TMS, if you've ever had that, it's just like a tap on the scalp. And the peripheral nerve stimulation, let me think where that was. That was in the popliteal fossa, in the posterior tibial nerve, so behind the knee. And that would feel like a flick if somebody's flicking you behind the knee. And that's all you feel. And they're so close in time, 20 milliseconds difference, one preceding the other, that they feel like they're at the same time. And so that's what you'd feel, a little flick behind the knee, a little tap on the head, and then that's repeated. I believe we did that about once every 10 seconds. So it's very tolerable.
Okay, gotcha, thanks.
Yeah, good question, thanks. All right, folks, I hope that was useful, and enjoy the rest of your day. Bye.
Bye.